Shaping the Future Pediatric Endoscopy Training, AI Innovation, and Next Generation Pediatric Endoscopy by Dr. Nattapong Akkarapon. He's an associate professor in pediatrics at the Department of Pediatrics, Chiang Mai University, Thailand. He's currently the chair of the Aspagan Endoscopy Scientific Subcommittee. He received his postgraduate training from Louisiana State University in the US. And he's also a member of Thai Society of Pediatric GI and Aspagan. He published over 60 articles. His research interest is on endoscopy, viral diarrhea, and biliary atresia. Please, Professor Nattapong.
Thank you very much for your kind introduction, and good afternoon again. Thanks for being with us until the last topic, and I will share our journey of endoscopy. In the early endoscopic era, instrument consisted of a short, rigid metal tube simply lit by a candle. You can see in the picture. The advancement of endoscopy in the late 80s hinged on two major developments: a prototype of wart swallower esophagoscope invented by Professor Kochmal and a two-part gastroscope invented by Professor Elsner. The rigid era changed to semi-flexible endoscope, which was introduced in 1932 by Professor Schindler. He is being accepted as a father of gastroscopy. His concept directly paved the way for the next great leap, that what we call is the fiber optic endoscopy. When I was a young staff, I still used the fiber optic endoscopy to do the endoscope for small kids. And this slide shows Professor Schindler was performing his gastroscopy. For 3 decades, we used fiber optic endoscopy before digital processing technology disrupted the procedure. The innovation led to a video endoscope, which provide superior safety and significantly more advanced imaging capabilities. Due to rapid advances in video endoscopy, artificial intelligence, especially for deep learning method and convolutional neural network, or CNN, is now part of our endoscopy. The initial clinical focus was computer-aided detection system for colonic polyps. With the increasing evidence from randomized controlled trial of the computer-aided detection system, commercial computer-aided detection system quickly achieved regulatory approval and integrated into many endoscopy devices. Currently, innovation accelerating and moving exponentially from simple detection to what we call it computer-aided diagnosis, or CADX. And this include histology and invasion prediction, and also polyp characterizations. AI endoscopy systems are now accepted in many clinical guidelines. Furthermore, these recommendations extend beyond the procedure itself, but incorporate the role of AI in shaping future of fellowship training, quality control, and therapeutic decision assistance. Of this, quality assurance has a big gap. Our survey showed that only 17% of medical schools apply or use Penguin system in their routine clinical practice. Here are examples of core metrics monitored by AI system, such as bowel preparation adequacy, cecum intubation rate, and adenoma detection rate. The AI system transformed a semi-objective score from the traditional Boston bowel population scale as Professor Ponte lectured for us earlier into an estimated score. In this paper, they called EBBPS. A cutoff score of less than 4 was then more objectively defined as adequate or qualified bowel preparation. The study using the estimated score from the AI system show the important link between good bowel preparation and lower adenoma detection rate. In addition to bowel preparation adequacy, a withdrawal time of more than 6 to 8 minutes is also important for maximizing adenoma detection. The study confirmed the superior adequacy of AI-based withdrawal time, showing a high correlation with ground truth video review, which is used as a gold standard for comparison. And it's very surpassing the reliability of real-time human documentation, as you can see on the right-hand side, on the graph in the right-hand side. The AI system can further refine this measurement by calculating the effective withdrawal time, not just a raw withdrawal time or just a simple withdrawal time. It's the effective withdrawal time. That's counting only wall view images that is used as an adequate view of the endoscope for more or effective, adequate bowel preparation. In that study, they found that every 1 minute, increasing in effective withdrawal time leads to almost 50% increase in adenoma detection. Of course, training remains challenging, and we found an overall adenoma miss rate of about 30% among US trainees, particularly for small polyps distal to splenic flexure. And the detection performance is further reduced for sessile-serrated lesions. And with the AI assistant, miss rate are reduced by approximately half, as you can see in this slide. If we start with the AI assistant system, the adenoma miss rate is reduced from 32% to 15%. The next 2 slides, I will present 2 recent studies showing the efficacy of AI in detecting of adenoma. This study shows a 1.4-fold improvement in detection with the help of a computer-aided detection system. And another study showed a modest, but a little bit lower, roughly about 1.2-fold improvement in ADR. Although benefits are evident, clearly evident, but concern still persist regarding AI dependency, delayed mastery, and misclassification, resulting in over resection or biopsy of benign lesions, and sometimes endoscopists have to take more time to perform the endoscopy. Mucosal folds, stool, and bubbles account for many fault detections by the AI system. So longer alert thresholds may reduce false positives without loss of accuracy. In this study, you can see that if you set the false positive alert more than 2 seconds, the accuracy is still acceptable, is as high as 99.9%. At this point, several limitations need urgent attention, especially in the field of pediatric endoscopy. What I talked earlier, most study or most development is based on adult endoscopy. But for pediatric endoscopy, we have many limitations for developing of the AI endoscopy. The first one is limitation and non-diversity of pediatric data. Data collection is the most important for training of the AI in the computer, and the different anatomical landmark is also one of our limitation. Heterogeneous pathologies and lack of explainable AI. So, what is an explainable AI? So we don't really know for sure what it has learned in that, what we call is a mystery black box, because the AI will not explain me why they think in that way or another way. So it's still in the mystery of its learning in the black box. So to overcome this limitation, future efforts must prioritize, I would say, that multi-center data collection with rigorous ethical oversight. That is very important to create large, diverse, and well annotated pediatric data set. If we have enough amount of the data set, which is very diverse in pediatric population, we can train the computer to help us for as an AI for taking care of our pediatric patients. So this is my last talk, and thank you very much for your attention. And I think this is kind of news for us in this field. If anyone want to share, I would be happy to hear that. And to me, my experience is very limited about the AI in the pediatric endoscopy. Thank you very much.
Thank you, Professor Nattapong.